Thank you for a nice introduction and inviting me, Kuwait Hematology, for my talk, Management of High Dose Methotrexate, which is really not one those common medical condition like stroke, which has gained a lot of attention door to death time. However, high dose methotrexate is really true a medical emergency, which we discussed today. So, good evening, ladies and gentlemen. Next 20 minutes, I have divided my talk in 5 parts. So, first part, I will take you basic of the high dose methotrexate, going through the mechanism, its indication and clinical application. Second part, I will take you how to monitor the methotrexate and what are the preventive strategies and treatment strategies. Third thing is what is the role of glucocorticoid enzyme. And the fourth part, I will take you some research and resources to solve the challenge and real world case and summary and final take. And the fifth part is like, how do you predict high dose methotrexate in 2023? So how do you manage high dose methotrexate? Which guideline used to treat hematology? Actually, we use 4 guideline and NCCN is the top of it. And for expert online, methotrexate PKORG. So this is NCCN guideline for the best supportive care. And they are indicating hydration, leucovorin, but recommended in some circumstances as indicated here, glucocorticoids, which we discuss shortly in detail. Now, question is, what is methotrexate? We have wide variety of professional background here. So I give some quick impression of the methotrexate. So here you see methotrexate and folic acid, which looks both same type of molecule. If you have molecule of folic acid or methotrexate, and now the thing is who will go into the cell by the active transport. This depends on the concentration. So if you have high dose of methotrexate concentration, you are competing with the folic acid, it will compete, it will go into the cell and it will not allow the folic acid to go. So once it is in the cells, what it will do, it inhibits the DNA synthesis. DNA is also important for maintain the survival. Cell cannot replicate its DNA, so it will eventually die. So that's why it's called methotrexate is called cytotoxic chemotherapy agent. So it will work on S phase and paralyze the enzyme we call as a dihydrofolate reductase enzymes. And so in perfect word, what happens, dihydrofolate reductase enzyme, what it do, it forms the reduced folate that forms the purine and pyrimidine, which are the building blocks of the DNA. So if methotrexate is going to the cell, what happens, it paralyzes the dihydrofolate reductase and it will not allow the formation of the biosynthetic, this process. Now, once methotrexate enters the cells, and it also enters the cancer cell and normal cell as well. So if you want to rescue the normal cells, what you do, give the healthy cell the reduced folate. This reduced folate will go to the healthy cells. It cannot go to the cancer cells. So this rescue the cells and therefore it will activate the normal cells. So now, what is the high dose methotrexate? By definition, it is 500 milligram meter square over 2 to 36 hours. High initial plasma concentration above 1 micromillimole for at least 12 to 30 hours is needed, and you require hydration and leucovorin rescue. You can see here where it is used from solid tumors to hematological malignancies in different doses in different duration form. The prolonged exposure of methotrexate due to delayed elimination increase the risk of systemic toxicity. This is the graph we're showing, this is the normal. Within the 24 hours, you can say its level go to the 10-6, and then within the 48 hours, it's almost eliminated. If it is not eliminated, it causes the toxicity. Timing is crucial. It damages the different organ. The most organ damage is the kidney, which is 2% is seen in the children and 12% shown in the adult cases. Now, prolonged exposure of the methotrexate, they cause non-renal and renal toxicity. Non-renal toxicity is the cells which are heavily growing cell like GI, bone marrow, and neuron, hepatotoxic. So these are accumulated in these cells. If it's not eliminated, it damages these cells. And nephrotoxicity is depends on the pH of the urine, because if pH is less than 7, it forms crystals that called urinary tubular obstruction and nephrotoxicity that reduce the GFR. And this is called increase in methotrexate serum concentration, which is also called DME. DME means delayed methotrexate elimination. So it depends on the urine pH. Higher the urine pH is better for not having the toxicity. So before starting the high dose methotrexate, it's very important to identify the drug which can cause high dose methotrexate toxicity. So suspend medication that interference the methotrexate clearance. Those are the medications are from non-steroid anti-inflammatory, antibiotic, PPI, antifungal. So you have to identify this thing. This is the first thing. And then second thing, you have to anticipate the which patient may have this problem. The patient who have high BMI, pH urine is less than 7, whose creatinine is less, and who are elderly patient, who have volume depleted patient, and the patient who have third space accumulating fluid. These are the high risk of the patient. Based on this, you have to predict. This is the rapid clearance of the patient, this is the average clearance, and this is the delayed clearance of the patient. Based on this, you have to identify the patient and you have to monitor accordingly. So now how to monitor the management of the high dose of methotrexate? There are 3 steps: monitor, prevention, and the treatment. So how to monitor? Key parameter is the early detection of the DME is the monitor. The monitoring is 2: serum methotrexate level, which are actually 2 ways you can do it. One is immunoassay method, other is chromatography. Immunoassay is rapid, but the problem with immunoassay is they will also count also metabolites. They will not count, separate the metabolites. But chromatography method, you will calculate methotrexate and metabolites individually quantified. So this is the advantage of chromatography. Anyway, you have to urine pH is monitored, and urine pH is alkalization therapy that adjusts based on the urine pH. You have to check the creatinine, you have to check the liver function test and the CBC. So this is how you do monitor. Monitoring start actually after 1 or 2 days after initiation of methotrexate, depending on the dosage, infusion, and the protocol, different protocol. So as I mentioned, methotrexate concentration following the new drug, which is called glucocorticoids, can only be reliably measured by the chromatograph. You can see here, this is the red is the this is the serum creatinine, which is the serum creatinine rate. Serum creatinine high when the patient was given glucocorticoids. You see this green is this is showing the normal method, and this is the chromatography method, blue color. So this is showing the clear cut the level of methotrexate is going down, but this is misleading. So this is very important. One should understand the chromatographic measure. So now, what is the prevention? Prevention is first good hydration, urine alkaline, and liquor rescue. Liquor rescue, again, is very important to measure the dose. Depending on the dose, depending on the level of methotrexate, the dose is changed. Here you can see the dose is 10 to 100 milligram per square. Again, duration from 6 hours to 3 hours. Depending on the level of methotrexate, you have to give rescue. Now, how to make diagnosis is depending on the dose is given and the duration and the serum creatinine. It's very important. Delayed methotrexate elimination usually related to renal function, reduce the GFR, and it causes the problem and oligouric. So now, if it is there, high dose methotrexate, it is not excreted, there is problem with the GFR, then what you do, you will do increase the hydration, increase the leucovorin accordingly, as I mentioned, dose and frequency. But even though if it's not effective, then you have 2 methods you can do it. You can do either a dialysis method, or you can do the new enzymes, which is called glucocorticoids, which is effective in 15 minutes, actually 5 minutes injection within 98%, which I show shortly. Now, what is the glucocorticoids? it is actually recombinant enzyme. It metabolizes the methotrexate. Here you see this is the this is actually affects actually not intercellularly, it affects only extracellularly. So this is the glucocorticoids. This cleave the methotrexate into its metabolites, which are non-toxic, and this affects. So indication is where when methotrexate concentration greater than 1 micromole and plus patient has impaired renal function. So this is the indication. There is limitation of glucocorticoids. You cannot do for all the patient in which you expect the clearance methotrexate with the hydration and leucovorin. This is the summary of the all mechanism. You're seeing you have given first methotrexate. It inhibits the dihydrofolate reductase and inhibits the DNA. So, and you have given now leucovorin to the normal cells. They rescue the cells. And if methotrexate elimination is impaired, very high dose of leucovorin is necessary. And if it is not possible, then finally you can give glucoparadise. Now, whatever I talk, this is without data or data, as somebody mentioned, without data, you are just another opinion person without opinion. So now the thing is, there are some clinical trials which you have shown that about 1,000 of the patient, and the most important thing, they have shown that glucocorticoid reduction was seen in 15 minutes, and all the data overall within the 5 to 15 minutes. So here is the key. Timing is very important. Clinical trials suggest the time to reduce plasma pentatoxide level. Glucocorticoid act within the 15 minutes. Here, this is the graph within the 15 minutes, but dialysis take times and leucovorin takes even more time. So depending on the level and the serum creatinine, you have to do accordingly. What is the algorithm? Algorithm is like this way. After 24 hours, after 36 hours, and then 48 hours, you have to monitor methotrexate and creatinine. If methotrexate is more than 50 and creatinine is problem, and even within 24 hours, you can use it. But if it is not problem, you don't use this one. You have to use the only leucovorin rescue. You can see if there is no problem and the level is normal and the creatinine is good, you can continue just leucovorin rescue. But anything happens like high creatinine or very high level of methotrexate, depending on this, you can use glucoparadase. Now, how to use it is very important. You have to use research and resources to solve this challenge. There is actually methotrexate PK.org. This is free, easy to use web tool. You can use the patient methotrexate pharmacokinetics very easy. It's just put it in the Google and you can find, and then you put the patient data, age, gender, weight, height, and the dose, how much methotrexate you use, what was the duration, and then the creatinine and clearance and everything you put it, and finally it will go to this way. This is the graph of one of my patient who is a 52-year lady, ALL, who is in a high dose methotrexate, now is cycle 3 and part B. So in this part, actually, first time we noticed the patient creatinine increase. And this is, this is the creatinine curve, and this is the green is population mean, and the red color is upper limit, and this is the patient curve, black color is the patient color. Now you can see here, I show you, this is the real curve which I took from my patient's file. This was January 1st dose when methotrexate was given. You can see it was level was just low and it was controlled with the leucovorin. Then second cycle, methotrexate level was high. It was also controlled by the leucovorin rescue. But the third dose, it went very high. Then this time, based on the level, it was level here actually between 0.5 to 5. So I used in this patient actually 100 milligram meter square every 3 hours the leucovorin, and then you can say it went down. So in this patient, with the help of leucovorin timing giving, it improved nicely. So this is the summary. Methotrexate can be given safely in patients with a normal renal function. Successful management is possible if you recognize early and eliminate the renal function just with a good hydration, leucovorin, and glucoparadase is given in some circumstances, as I mentioned. So in the last 20 minutes, I took you the basic of the high dose methotrexate mechanism, indication, and burden of the disease. I took you how to monitor it, what are the preventive strategies, and what are the treatment option. And the important thing, I have shown you the advantage of glucoparadase, which is now FDA approved from 2012, and it can be given safely. But to whom to give, there is a guideline, there is research and resources. You can put in methodpk.org, put the data of the patient, as I mentioned, how I treat, and you can check it is needed or not needed. And then final question is, how do you predict methotrexate, high dose methotrexate in 2023? So thank you very much. I am here if any question. Thank you for listening.